Welcome everyone. On behalf of the Association of State and Territorial Health Officials, also known as ASTHO, I would like to thank you for participating in today's webinar entitled, Are You Ready to Sail Your Ship? Today's webinar is being recorded and you will receive the link to review the presentation once it is posted to our website. My name is Denise Pavletic, and I'm the Director of Public Health Systems Improvement at ASTHO, and will be presenting and moderating today's session. This webinar is the final webinar in a series of 4 that ASTHO has hosted on the topic of developing a state health improvement plan. Today's webinar is brought to you through funding and partnership between ASTHO and the Centers for Disease Control and Prevention, Office of State, Tribal, Local, and Territorial Support. The content of this webinar are those of the authors and do not necessarily represent the official position of or endorsement by the Centers for Disease Control and Prevention. Additionally, the information provided in this webinar is intended to be consistent with PHAB requirements and documentation guidance. However, ASTHO cannot guarantee that states who follow the guidance in this document will meet PHAB requirements, as only the PHAB site visitors can make that determination. Today's webinar objectives are to explain the purpose of including objectives, strategies, and measures in your SHIP, identify structures for developing SHIP objectives, strategies, and measures, and then develop an action plan for preparing and implementing a SHIP. At the conclusion of the webinar, you will be directed to a link to answer a few questions on how well we've met these objectives. So in the spirit of our own quality improvement, we very much value your feedback, so please take a few moments to complete the evaluation. And we are very excited to bring you today's webinar and look forward to answering your questions throughout the session and at the end of the presentations. If I can take a moment to orient you to our ReadyTalk platform, there are 2 ways in which you can submit your questions. The first is through the chat function located in the lower left corner of your screen. You can submit questions at any time throughout the presentation using this function. So let's quickly get some audience participation using the chat feature. Right now we have about 30 folks on the webinar today. So through the chat function, tell us the agency and the city where you are, and I can start us off. Great. See, people have responded here. We see, it's going fast, Arkansas, Maryland, New Jersey, Kentucky, great, Missouri, Health Policy Institute of Ohio and Columbus, Harrisburg, great, Wisconsin, California. Great. So we have a wide variety of participants. So again, please use that chat function as the presenters are presenting, and we will address those at the end. The other option is to actually ask an audio question and speak to the presenters directly. So what you'll need to do is hit *1 on your telephone keypad, and then the operator will put you in the queue to ask your questions. And we encourage you to ask questions. I'm sure many participants have the same or similar questions, so don't be shy in putting forth your question. So I'm very happy to present our presenters for today. First presenter is Priti Irani. She is a research scientist with the New York State Department of Health Office of Public Health Practice. And she also serves as the State Healthy People 2020 Coordinator. And that is the Healthy People 2020, and also serves as the State Healthy People 2020 Coordinator. Ms. Irani assists with the implementation of the Prevention Agenda, which is New York State's Health Improvement Plan, and reviews the plans submitted by hospitals and local health departments as required under public health law. She is also the staff liaison for one of New York's 5 priority areas in their SHIP. Ms. Irani has a Master's of Science in Public Health from the University of Massachusetts in Amherst. Our second presenter is Sylvia Pirani. Sylvia Pirani directs the New York State Department of Health Office of Public Health Practice, which leads New York State's State Health Improvement Plan. Ms. Priti oversees the office's provision of technical, administrative, fiscal, and data support to New York's 58 local health departments. She also oversees an initiative to integrate performance management and quality improvement into the state's public health programs, and led the department's successful application for public health accreditation in 2014. So we congratulate New York on being an accredited state. Ms. Prati has a Master of Public Health and a Master of Science in Urban Planning from Columbia University. Next, our colleagues from Alaska. Michael Dickey is the Quality and Performance Improvement Manager for the Alaska Department of Health and Social Services Division of Public Health and serves as the co-chair for their SHIP, which is called Healthy Alaskans 2020. Over the past 15 years, Mr. Dickey has worked on national, state, local health initiatives in the areas of performance improvement, coalition development, health equity, behavioral health, and policy, systems, and environmental change. Mr. Dickey has a Master's in Public Health from the University of South Carolina. And then finally, Dr. Diana Redwood is a Senior Epidemiologist at the Alaska Native Epidemiology Center, Alaska Native Tribal Health Consortium, also known as ANTHC. Her professional expertise is in public health and epidemiology with a focus on cancer screening and prevention. She has worked at ANTHC since 2004 and managed colorectal cancer projects at the consortium for the past 7 years. Dr. Redwood received her Master of Public Health and Master of Science in Nutrition from Tufts University and her PhD in Public Health from the University of Alaska, Fairbanks. So let's jump into a little bit of history about ASTHO's developing a State Health Improvement Plan guidance and resource. In the summer of 2015, we released this guidance and resource document as a sequel to the State Health Assessment Guidance and Resource that we released in 2014. Both the SHA and the SHIP resources are companion documents and were meant to be used together. ASTHO would like to take this time to recognize the partnership with our colleagues at the Illinois Public Health Institute in creating this guide, and also recognize our expert SHIP Advisory Committee who provided invaluable input into this resource. So how do you find this resource? You'll go to www.astho.org. You're going to click on Programs, and then Accreditation and Performance. That will bring you to our landing page where you'll click on the Tools Clearinghouse under the Resources tab. Note here that the Tools Clearinghouse section has several resources including case studies, toolkits, peer network information, newsletters, webinars, sample SHAs, SHIPs, and strategic plans, presentations and fact sheets, and an accreditation library where we house example accreditation documentation by standard and measure. And then once you have clicked on the Tools Clearinghouse, it will bring you to our SHIP landing page, and then at the bottom you'll see the link to click on Download the link. And before the download begins, you'll be directed to complete your name, agency name, and your email address. And we're using this information to provide follow-up on the toolkits and to use for our evaluation of the toolkits. Our State Health Improvement Plan guidance and resource includes 7 modules: identifying and engaging stakeholders, engaging in visioning and systems thinking, leveraging data, establishing priorities, communicating about your SHIP, developing objectives, strategies, and measures, and implementing and monitoring the SHIP. In today's webinar, we will be focused on Modules 6 and 7, developing objectives, strategies, and measures, and then implementing and monitoring the SHIP. Each module contains a preview of the content, the relevant PHAB standards and measures, ideas for structuring the planning process, important considerations, key terms and acronyms, and most importantly, state examples and lessons learned, and sample tools and links to many resources. And then throughout the document, we cross-reference to the State Health Assessment Guidance and Resource as well. And as I previously mentioned, each module has an extensive list of resources and links related to the module topic. And each module contains the relevant reference to the PHAB Standard 5.2, and we also reference other related standards throughout the resource. And last, each module contains a section on important considerations with, once again, relevant resources. So let's jump right into Module 6, Developing Objectives, Strategies, and Measures. Once your priorities have been determined, the next step is to define the desired outcomes through measurable objectives, identifying evidence-based strategies, and a framework for implementation and measurement. Some of the peer lessons learned that we captured in the guidance and resource document at a very high level include create a realistic timeline, create and facilitate effective meetings, engage subject matter experts as soon as priorities are selected. Stakeholder engagement needs to be ongoing. Begin the process with a scan of existing plans and efforts. Work to maintain stakeholder involvement. Allocate staff time to support this work, and take time to identify improvement opportunities. State health departments must engage partners for collaboration on SHIP implementation in order to improve the health of all populations within the state. Partners should include a variety of stakeholders with a diverse geographic and population reach, and have the ability to implement strategies and activities across the social ecological model continuum. And so you see here in Figure 6.1, the social ecological model includes a continuum of activities that address multiple levels across the lifespan and the diversity of the state's population. Stakeholders who are engaged in the improvement planning and implementation process may be organized into a variety of different structures. These structures often include a multi-sectoral SHIP partnership consisting of oversight and guidance, data and evaluation expertise, and work groups for each of the priority issues. PHAB provides guidance on expectations regarding the State Health Department's collaborative partnerships that can help guide the development of the SHIP partnership. And the partnership and State Health Department should identify stakeholders who have content expertise and the capacity to address priorities through a variety of different strategies, including policy, systems, and environmental change. And then work groups are charged to develop and adopt implementation plans that are aligned with other plans. One of the first steps in developing a plan may include discussion and decisions on some important exploratory questions. So some important items to consider are identification of current initiatives being implemented and determining which are working or making progress and which are ineffective and why. Consider the overall desired identification of high-level long-term goals for each priority. Discuss how progress and success can be measured. Determine linkages and alignment with other strategic plans and initiatives. Discuss and identify potential opportunities that may support the implementation of collective efforts to impact a priority. Discuss and identify potential challenges and threats. Discuss types of resources, strategies, and activities each partner is best suited for. Identify individuals and organizations needed to be engaged on the work groups. Working with the partnership to answer these questions for the identified priorities lays the groundwork for developing objectives, strategies, and measures, and ultimately solid implementation plans. There are many tools that can be utilized to support the development of objectives, strategies, and measures. Some of the tools explored in this module include root cause analysis, tree diagrams, and logic models. Many SHIP Advisory Committee members reported that stakeholders experienced differences in the use of terminology. Therefore, it is critical to determine a common set of definitions for key terms and continually reinforce the agreed upon definitions to assist with implementation planning across multiple stakeholders and work groups. And then of course, as stakeholders convene to plan the development of goals, objectives, strategies, and implementation plans, it is important to remind planners to utilize data from the SHA that supported the selection of priorities so that decisions about objectives and strategies are also made based on data. Distributing an overview of the data related to each priority is a good place to start, and this data will also need to be summarized in a brief description for the SHIP document. And a logic model can be used to help define and communicate alignment of strategies, objectives, and goals. While some people shy away from logic models because they fear its complexity, logic models can actually provide a process and structure to demonstrate this work in a fairly simple manner. Logic models are usually displayed visually, but the form of the picture varies. Logic models typically have two common visual displays. They are either in a series of columns or a flow chart depicting boxes and arrows. Either of these visual displays will work for clarifying the relationship among strategies, objectives, and goals. But a flowchart format makes it easier to visualize the relationships among the plan components as pathways. And then next is a quick overview of Module 7. PHAB Measure 5.2.2, 5.2.3, and 5.2.4 outline what the SHIP must contain. The transition from planning to action is often challenging. To help with this transition, use the priority work groups to develop a clear work plan or action plan for each priority. The work plan should outline specific activities, accountabilities, and timelines as shown here in Figure 7.1. Washington State drafted the Public Health Improvement Plan Agenda for Change Action Plan in 2012, which clearly reflects the strong partnership between the state and local health departments on the Public Health Improvement Plan, and includes focused attention on local health jurisdictions working with local partners on achieving the objectives of the plan. More current practice suggests that states may want to include accountabilities or other stakeholders and sectors that are part of the SHIP partnership. And then last in the SHIP Guide as a resource, we have several case studies and success stories. We feature Minnesota, Wisconsin, and Illinois as case studies. We feature Florida and New York. They're tracking state and local alignment around priority issues, which we will hear about in a little bit. Maryland, monitoring and evaluating state and local process. Connecticut's Healthy Connecticut 2020 Performance Dashboard, and then also New York's Prevention Agenda Dashboard. So be sure to check out our guidance and resources for further details on that. So that all being said, I will pass it over to my colleagues in New York.
Thank you. Hi, this is Sylvia Pirani. Very happy to be with you this afternoon with my colleague Priti Irani. And I'm going to start this off to talk about how we developed objective strategies and measures and the stakeholders that we worked with. So if you could go to the next slide, please. Questions at the start of the process. This was some of the things that we asked ourselves and that you may also be asking. How do you involve stakeholders? Who are they? How long? What kind of structures do you use to keep them involved? What kind of planning tools are helpful? And Denise went through some of those. How do you select objectives? How do you make sure your SHIP is aligned with ongoing plans that different divisions or bureaus or the federal government may have, like a maternal and child health block grant, for example? How do you select strategies? And what's the process for developing outcomes, both in long-term and short-term outcomes? So if you could go to the next slide, that'd be great. So last time we spoke a little bit about our structure for stakeholder involvement. We have a state public health and health planning council, which is like our Board of Health in New York. It has a public health committee, and that public health committee has a responsibility for overseeing the development of the state health improvement plan, and so it has appointed an ad hoc leadership group to lead the prevention agenda 2013-2018. So this includes members of that public health committee as well as other sectors that you see here: healthcare, business, academia, community-based organizations, local health departments. So that group had been involved in our previous prevention agenda, and then when we got together to develop this one, you'll see later that we added to some stakeholders as well. If you could go to the next slide, please. So we talked a lot about the framework that we were using to define our state health improvement plan. We were, and we worked on this with our ad hoc leadership group, and we agreed that the goal was improved health status with a focus on prevention and with a focus on health disparities. And we used this determinants of health slide, this background to really call out the focus on prevention, that contribution to premature death is the things that contribute to premature death are really outside of a clinical setting. They're socioeconomic status, behavior patterns, the communities that people live in, environmental exposure. So that's really what we wanted to focus on with our SHIP. And then the other important point is that for us, our SHIP is a call to action to a broad range of stakeholders, not just at the state level, but also at the community level, to conduct their own local health assessments and and develop their own community health improvement plans. So we have linked very strongly our prevention agenda with the local community health improvement planning process that is required for local health departments and hospitals to meet as per state public health law, in addition to accreditation. So if you could go to the next slide. We drafted a set of principles, and this was edited and reviewed, and we had gotten some stakeholder feedback that helped inform these principles as well. So this is what the group as a whole came up with. The first goal reflects the overall purpose, which is to improve health status in 5 selected priority areas and to close important disparities in those areas through the interventions that are designed. The plan aims to lift all boats, but also to close gaps. The second goal is to promote the broader determinants of health, factors like education, income, and housing that have been shown to directly influence a person's health status. The idea of health in all policies, as you know, is captured in the fact that governmental policies that address many aspects of our daily lives and the conditions in our communities can have a positive or negative influence on our health. So we want to raise awareness and promote action and accountability for the health impacts of all public policies and investments in multiple sectors. The third is to create strong partnerships and again, we talked about this at both the state level and the local level, and that you need both public and private participants to help achieve our goals. The fourth principle has to do with articulating the need for increased investment in prevention and public health. We've had some additional investments in New York State, as other states have, in health care reform, but we really need also additional investments in prevention and public health. And the fifth has to do with strengthening that public health and governmental and non-governmental public health agencies and resources, including our sister agencies, Office of Mental Health and Office of Alcohol and Substance Abuse Prevention, as well as the local health departments. So if you could go to the next slide. So this talks a little bit about our process. So last time we talked about the development of our state health assessment, and we used that data to come up with a set of priorities for our leadership group to finalize based on some stakeholder feedback. We also used our experience with our previous prevention agenda, which had 10 priority areas. And so we felt that that was too many priorities, and also some of them were more clinically focused, related to getting people access to health care. And we felt that with the advent of the Affordable Care Act, we could focus on that a little bit less. It was sort of an overall principle, but not one of the priorities that we were going to focus attention on. So these are the 5 priorities that we came up with. They reflect the stakeholder feedback that we received. We as a state health department would normally propose promoting mental health and preventing substance abuse as a priority of our state health improvement plan, because we don't deliver those services, but the stakeholders felt it was really important in an overall state health improvement plan to include those, and so that helped us strengthen our partnership with those state agencies. Okay, so now we have a poll question for you to ask you whether the stakeholders that work on your state health assessment the same as those working on your SHIP. Okay, pretty fast. Some people said, oh. People still voting there. Okay, so 2/3 of you, a little bit more than 2/3 of you said yes, the same, and a quarter said no, and some don't know yet because you probably haven't gotten far enough along in the process. So there's no right or wrong answer here, but you do, I think the point here is that you do want to think about it based on your priorities, that you might need to increase the number or change the kinds of stakeholders, or increase them, add additional people to your plan, to your engagement group. So if you go to the next slide, we can show you the structure that we use. So I talked about this a little bit. We have our Public Health and Health Planning Council has this Committee on Public Health. We're fortunate in that Dr. Joe Ivy-Buford, who's the president of the New York Academy of Medicine and led the Institute of Medicine report on public health, strengthening the public health system 10 plus years ago now, is the leader of our Public Health Committee, and she leads our ad hoc committee and is very invested in our work, which is great. And that original ad hoc committee had 21 members. We have increased it since, but then more importantly, when we identified those priorities, the process we used was to come up with priority-specific action plans, and we gave ourselves 3 months to do that. We did the whole SHIP in a calendar year, started in January, finished in December, because we were committed to submitting our PHAB application the following month, in January of the following year, so we needed it done. So we moved pretty quickly on this. We created robust committees, and you see there in parentheses the number of people on each one to come up with those action plans. 35 people for chronic disease, 25 for healthy and safe environment, et cetera, et cetera. When you get to the 5th priority there, HIV, STDs, we had 3 subgroups, because it's 3 sort of different issues that fall into the infectious disease priority. For some, they were obvious partners. For others, they were brand new partners. The most challenging one, I think, maybe for mental health prevent substance use. We had a lot of people who knew how to deliver services in those areas and how to deliver treatment, but not so many that were focusing on prevention, so that was a challenge. With the Promote Healthy Women, Infants, and Children, we have as many of you do, probably all of you do, have a maternal and child health block grant advisory council. We had the co-chair of that, the chairperson of that advisory council co-chaired this group for us. We wanted the two processes to align as much as possible. We didn't want to duplicate, have two different plans out there for that population group. So we joined forces with that committee, as well as added some new people to it. So I think people felt like it was a good refresh of that group. It helped both projects. So again, we had these committees meeting over a 3-month period. That steering committee you see at the top, this purpose of the steering committee was to keep everybody informed about what was going on. Some priorities had issues that were cross-cutting. Breastfeeding was a priority for healthy women in addition to preventing chronic disease. For example, there's other examples. Tobacco is a priority for chronic disease. It was also a special focus for addressing tobacco use among the population with mental illness. So we wanted to communicate. That steering committee doesn't exist anymore. It was short-lived, but it helped us when we were developing the plan. But the ad hoc committee is still very strong. So if you can go to the next slide. Just some considerations for stakeholder composition and engagement. We needed to increase the diversity both geographically and of some different constituencies. As we mentioned, we needed to add some content expertise, specifically the state mental health substance abuse agencies as well as other organizations. We got referrals from state associations, from staff for people to add. And we wanted people, again, scope of influence, not just treatment, but also prevention, on our ad hoc committee, we try and have people that have statewide scope of influence, whereas on these priority-specific committees, it was okay if they were more locally focused. Next slide. Next slide is a poll question. So these are our questions for you. What questions do you have now before you get started in this process, or did you have at the beginning of your process? Are you going to need to change goals from things that you already established, like your block grant? How many staff will you need to do this work? How are you going to do all this addressing the priorities? And the same thing with focusing your priorities. It's easy to get really broad. How do you focus it? And then how do you do this in a short time frame? Okay, so getting it all done was a big question for us all the time, so I appreciate that. But you have those concerns. And not too many people concerned about changing goals. Okay. That's great. And then we have one more poll question before I turn it over to Priti. Does your SHIP or will your SHIP include a mental, emotional, behavioral component? Okay, pretty clear on that. So we weren't alone. Oh, no. So a third said no. Okay.
All right, so this is Priti, Irani. Well, we initially, we did not want to include mental, emotional, behavioral health component in our SHIP because we had two sister agencies who do that. We didn't want to step on their toes. It was also not a PHAB requirement. We couldn't produce it as documentation, but the ad hoc committee was pretty adamant. They said, no, it's a public health issue. So we did include it, and so you see 75% said yes, 25% said no. And so the question was, we didn't have staff or a program focusing on this, so how do we work on it? So if you could show me the next slide, please. Okay, you can skip this one. This was a poll question. Okay, so the next slide is, so in terms of what helped us, all these questions initially in the poll question, do we have to change our goals? We don't have staff, can do this in the short time. What really helped us was these planning tools, because we really had to set a strong foundation. So the cultural and environmental conditions, the ecological model was one we used. We did reach out and try to get partners in every one of these little bubbles that you see. If you can show the next slide, please. Another framework that we used was this health impact pyramid framework. We tried very hard to focus at the bottom of this pyramid, so we understood that every part of this pyramid is important. And so we had to educate ourselves with, what it is that we're working on and what our different roles are. We have the next slide, please. And we also, within each of our work groups, some of us used priority-specific models like the expanded chronic disease model for chronic disease. And for the mental health substance abuse part, we used the mental, emotional, behavioral health intervention spectrum. And these were really helpful, not only setting the foundation, but in establishing the language. For example, I was the staff person for the mental, emotional, behavioral health part, and I really had no credibility because everybody else worked in the field and I worked in public health. And so every time I said something, it would be questioned, and it was helpful for me to go back to this resource and say, well, I picked it up from this particular publication, so it was established in the field. So if you could go on to the next slide, please. So our communication process was very mixed. Like Sylvia said, we had a very short time. We started working on our action planning in end of July, August, and we had to be done by September. So, and over the summer. So conference calls, in-person meetings. New York is a big state, so it's really hard to travel. We had small work groups within each priority, and we did get support from a small grant from the Robert Wood Johnson Foundation to help with crafting key messages. Next slide, please. So this is how each of our priorities area, the hierarchy was. And you saw something like that when Denise gave her presentation. So we had the focus areas, under that the goals, and then the measurable objectives. And then under that, the interventions by sector and by health impact pyramid. And if you could go to the next slide. So I interspersed this with what was in the guidance, the ASTHO guidance. And the one word, we actually debated this, but we took off was, we initially used the word strategies, but we found it was being used interchangeably with interventions. So then after debate, we decided we'd stick with interventions. It was more specific, and we were trying to get more specific information. And then we also, used instead of tasks, we used activities, and then we had short-term measures. So terminology is important because then we kind of know what we are saying. We're speaking the same language. If you can go to the next slide, please. Okay, so how did we go about making sure we were in alignment, at the local level, at the national level, at the state level? So at the local level, New York State has a public health law which requires local health departments and hospitals to submit periodic health assessments and health improvement plans. And so we have them, and we, look at them and review them, and be sure we summarize information and integrate with that. Our program staff give us feedback based on the reports they have. We had kind of organized stakeholder feedback, and Chang actually talked about it in the first presentation. We did it through surveys. Our ad hoc committee members would go out and get feedback on various aspects. Our work group members would go out, and then also reviewed by work group members who, as you could see, were representation of the different parts of the state and constituencies. At the state level, we did look at the previous cycle of the prevention agenda to see, where we were doing well, where we were not doing so well, and what we could do. Program reports, and also our sister agencies, mental health substance abuse agencies, shared their reports with us because they were also very keen on aligning with, all our work. At the national level, we looked at the Healthy People 2020, specifically the objectives, targets, leading health indicators, the National Prevention Strategy, and then key reports from the IOM, the CDC, the task force, and SAMHSA. So every one of these work groups looked at all of these aspects. You could go to the next slide. In terms of setting objective targets for the prevention agenda, each kind of work group looked at historical data review. Were we moving the objectives, the outcomes moving in desirable direction? And then they would suggest an improvement of 5 to 10%. If it was moving in the wrong direction, then maybe it was good that we just stayed where we were, or it was a 5%. They looked at the interventions available, what capacity we had, and what resources we had. We also looked if our data collection methods were the same as Healthy People 2020, and if we could use their indicators and targets. We did try to, if again the experts on the work group thought we could. And generally, an improvement of 10% was targeted for a majority of the 5-year objectives. And now I should say 6-year objectives, because we extended ours by 1 more year. So go on to the next slide, please. So here is an example of how we track our objectives, by and the different views, and how we compare it to the prevention agenda goals, and then we say whether it's improved or whether there's change or not improved. And this is our dashboard. Next slide, please. And so again, so part of it is, again, sharing this information in different ways so people kind of get it. So this is one way where we kind of identify our goals and what interventions that we are working on by the different 5 priority areas. The next slide, please. And over here, we put out these. We just recently put out this update again about goals, and then what are some evidence-based interventions that we suggest, and what are some examples of short-term measures, and some key resources. So this is a very filtered, and we kind of play on the power of suggestion. They could be doing 100 things, but these are the ones we think it would be really helpful strategically to work on. And this is for reducing obesity in children and adults. This is related to the chronic disease, prevent chronic diseases priority. Next slide, please. So this is again another way that we kind of shared similar information, and here we talked about it by the health impact pyramid. On the left-hand side, you see for reduced obesity in children and adults, what are the different activities that could be done, and on the right-hand side by sector, what health delivery could do, what employers could do. Next slide, please. So while reduce adults and children, there's lots of interventions that could be had. Like I said, we used the power of suggestion. We had special webinars where we talked basically the program, the chronic disease program, identified these 4 broad strategies and how people could reduce obesity, and then they kind of drill down under each of these. Go to the next slide, please. So specifically on an example again on adopting nutrition standards, they kind of identified what steps could be taken, like identify current procurement practices and opportunities for improvement, and so in the description about assessing food and beverage procurement practices, and again, how do you should assist with overcoming barriers, and what some common concerns are, and how do you monitor this implementation of spread of policies, useful resources to consider. And then on the right-hand side, they actually, outlined what the prevention agenda objectives were. And on the bottom half of that slide on the right-hand side, you see short-term performance measures. For example, they could count number of municipalities, community-based organizations, etc., that implement standards, and long-term performance measures. So we were trying to kind of say, this is the information you should be collecting. The next slide, please. Okay, and this is an example from a healthy environment, similar, again, by impact pyramid and by sector. Just another example. So another slide, the next slide, please. Okay, so I'm towards the end of the presentation. Does your state identify long-term and short-term measurable objectives in its SHIP?
We got to wrap it up.
All right, so most of you do. Actually, when we were working on the SHIP, like Sylvia said, we were working really quickly. We, 3/4 of you identified short-term and long-term. We mostly identified long-term. And a lot of our short-term indicators happened soon after we released the SHIP because it took us time. It took us time to build consensus with our stakeholders. If you could go to the next slide, please. So in conclusion, the objective strategies and measures serve as a roadmap. It helps us monitor. It helps us gives us a guide of where to go. And the different structures with different representations help with developing and getting buy-in for SHIP objectives, strategies, and measures. And in the action plan, these objective strategies and measures are used to track progress and establish common language for communicating. Next slide, please. So the PHAB feedback was that the documentation and work was relevant. What they said we could get better at was we'd identified too many priorities compared to the strategic plan. Next slide, please. So we still know we have a lot of work to do. As you can see, we get these reports every year. Our comprehensive report is due the end of this year, and we have external forces like the accreditation process, and the hospitals have the IRS rules that kind of influence how we work. The next slide. And you can see this is a map of the state and how the different priorities our different counties have identified and that they're working on. It just gives you an idea that if somebody's working on each of the 5 priorities, and everybody's actually working on chronic diseases. And the final slide, please. And so that's it. So I know you'll take questions at the end. So if you have questions, here's an email. Thank you very much.
Thank you, Priti and Sylvia. So now I will pass the baton on to my colleagues in Alaska. So go ahead, Michael.
So thank you all very much. This is Diana Redwood with the Alaska Native Tribal Health Consortium. And we did a presentation earlier in this series on identifying and engaging stakeholders. So we're excited to be able to talk more in this presentation on the implementation phase. So Healthy Alaskans 2020 is a statewide collaborative. Our vision is healthy Alaskans and healthy communities, and our mission is to provide a framework and foster partnerships to optimize health for all Alaskans and their communities, which is similar to probably many of you, different missions and visions. But for us, one of the interesting things about this was that it is the true tribal state collaborative, which is unusual among other states in terms of the focus on that collaboration and what that collaboration can bring. Our project is in the implementation phase, and I won't go into some of the background stuff. Hopefully some of you were on our earlier call, but Michael will now tell you a little bit more about how we got to the implementation phase. Just to provide a little background though, in our plan we chose leading health indicators, 25 leading health indicators that were narrowed down through overall state surveys of different experts and various community surveys, and so narrowed it down to 25 leading health indicators, and then also evidence-based strategies to go along with those indicators, which then were used to develop targets and then are planned that is in the implementation phase now. So I'll turn it over to Michael and have him talk a little bit about how Healthy Alaskans 2020 is supporting implementation of those overall strategies across our state.
Thanks, Diana. So first of all, I want to say that I think that we're all excited here in Alaska to be doing this. You know, we're just now in the implementation phase, so we've developed our framework and our strategy and our processes of how it's going to go, but there's still, I'm a little nervous just because there aren't a whole lot of examples of how states have implemented, you know, their full state health improvement plan, you know, that includes step-by-step processes and things like that. So we're kind of unique in that I think we're trying to do that. We'd love to hear from other states that have been trying to do something similar or have strategies to implement certain parts of their state health improvement plan. I think we can learn a lot from each other. One thing I did want to mention that, of course, makes Alaska very unique is that, you know, we really don't have any local health departments. So we have to rely on networks of coalitions and health improvement planning groups and other types of groups throughout the state, as well as the hospital system and a bunch of our other public health partners, traditional and non-traditional both. But I did want to point out that, you know, us doing this and trying this, we're putting it, Diana will talk about our pilot with 4 of the LHIs, but one reason we're doing that is we're doing a PDSA cycle on the pilot to see, you know, what is going to work, what's not going to work. Our partners, our coordinating partners who you'll hear about in a minute, you know, it's the first time we've done anything like this, so we're kind of using them as guinea pigs and going to get some feedback from them as well. And so I hope that whatever we learn, good or bad, will be beneficial to other state, local, and county health departments as well. So here's our implementation framework. I will say that we did an environmental scan looking for all different types of implementation frameworks and processes for state health improvement plans. Of course, the ASTHO guidance for developing a SHIP we reviewed and was helpful, as well as NACCHO's CHA and CHIP Resource Center that had some helpful information on it as well. And of course, we reviewed the PHAB guidance with that. We also kind of looked at what other organizations were doing and going towards as far as implementing action. So we looked at Robert Wood Johnson Foundation, Culture of Health, and their action plan and things like that as well to help educate us on how to best move forward with our conditions here in Alaska. And I did notice that Susan from Wisconsin, I think was on, maybe she still is. Wisconsin has an example of a framework or an outline in the ASTHO SHIP development guidance. And so this little structure may look kind of similar that's on the screen here. We liked the way it was laid out and it was simple, so we borrowed the look from Wisconsin. So there are 4, I went ahead, there are 4 parts to our implementation framework, which we call steps. And then there are, then for each step, we have strategies to address those steps. What you will not see today is there are additional activities under each of these strategies, each of these approaches here that resulted in being our work plan. So basically we took our outline and our strategies, and then we made a work plan to identify activities and key partners or who needs to be involved in that activity to address these 1, 2, 3, 4, 5 approaches that are listed here, as well as on the other steps as well. So just to give you an example of some activities for this, it would really be things like identifying potential audiences and venues to market our Healthy Alaska 2020 initiative, which Denise had mentioned at the beginning is our state health improvement plan. Another one would be identifying coordinating partners to serve as a lead organizer for each of the leading health indicators, and also identifying statewide coalitions and networks working on the leading health indicators. And this is something I think that's really important to us since we don't have established networks. You know, of course, there are people throughout the state who are working towards similar goals, but and as in many states, you know, these coalitions and work groups and other initiatives going on a lot of times are not really connected or aligned, and oftentimes we don't know they're even occurring. So one important thing that we have done is we did an environmental scan, but also a survey to find out which organizations and coalitions, hospitals to social services groups are working towards one or more of our leading health indicators that we've identified, the 25. And so what we're doing with that is we're putting all of that information and contact information and grouping them into these cohorts, LHI cohorts. And so that becomes a database and resource for our coordinating partners, who Diana's going to talk about, for them to be communicating and reaching out to this cohort, and which hopefully later can serve also as a community of practice. So the other one, we are on the second step is assuring effective actions and results. Some of these examples of activities that are under that we're going to be doing is creating accountability by developing clearly defined roles and expectations for all of the major HA 2020 players, providing opportunities for communities of practice and individual organizations to receive recognition and visibility for their work. We recognize that, you know, all of this work that's being done is they're not getting paid for. We don't have funding. We had some NIFI funding, and then when that went away, we didn't really have any funding. So we have to be really creative in doing a lot of this work and aligning strategic plans and other goals towards the HA 2020-25 leading health indicators. The next one is monitoring and reporting progress, which of course sounds pretty straightforward. I will say that, you know, we do have a dashboard that we report, that we update yearly, and those are long-term outcomes, and it's reported on each leading health indicator. But with our implementation plan, we've decided to also select a set of shared measures among these cohorts that are being set up and identify what one or two measures that they're already collecting that we could get information on that address the strategies in our SHIP. So they're not long-term goal strategy, long-term goal outcomes. They're, you know, what strategies are being utilized with different groups throughout the state, and what are some of those outcomes for those strategies specifically. And then sharing successes and lessons learned is the last one. We think this is, of course, really important for people to learn about our process. So we're really trying to document, you know, what we're doing and the processes and how we did it and the stakeholder engagement and things like that, so that, you know, when this is successful, we can share what we did at least. And I know Alaska sometimes is a little different than other places, but I think it might be useful to see some alternatives to information dissemination and alignment of strategies. So one question I was wondering, since we are having a hard time finding some concrete examples of processes and frameworks for implementing and monitoring a SHIP, I thought we could just ask if anybody out there has been involved in implementing either at the state, local, or county level, or regional level, or even within a community group. If you've had some frameworks or processes that you've used to find and found them successful, it would be interesting to hear from you all. Except I can't get out of here. There. So Diana's going to talk about your implementation models. One thing I did want to mention is that we're working really hard to align our SHIP with the community health improvement plans as well. Again, since we don't have which some other states don't have the local or county health connection to the communities. We're really working with our community health improvement program here at the state, who is our liaison to the community health improvement planning groups. And so we've really been working to share what our implementation is, our SHIP is, and also learn from the different communities of what their focuses are on their community health implementation plans as well. And so now I will turn it over to Diana, who will talk a little bit about the implementation model.
So what you see in front of you is our schematic. We've been calling it the egg for probably obvious reasons if you take a look at it. Basically what we're trying to figure out, again, as Michael has been saying, is what is a good way to implement this basically large state improvement plan that we've created, that a lot of thought and energy has gone into, and how do we actually make it happen given the few to zero resources, additional resources that we have to put towards it. So this model shows you, and I will talk a little bit more on the next slide about how our actual pilot is set. But we have planned to have coordinating partners, and these are key individuals who are knowledgeable about more of the leading health indicators. Have them working in concert with key partners that have been previously identified through the health improvement planning process. And then, of course, working with other partners. As you know, there's many people that work on different health issues, even if they might not think of themselves as working on that health issue. And so how do we get them all involved in moving forward our 25 statewide leading health indicators? And then, of course, we have a couple of Healthy Alaskans 2020 teams. We have a data team, a communication team, and a core team, which Michael and I chair to try and move things along. We also have an advisory team and a steering team. So there's a lot of different things, support that's going on throughout the state and to help the Healthy Alaskans 2020 implementation. So as I said, the coordinating partners, this was something that, again, we've sort of come up with this role, that they're established experts and champions. And the plan is that those will be the people who coordinate the leading health indicators work of the key partners. So trying to help help move that forward. And then of course the key partners are people who are experts, oftentimes agencies that were involved in creating the leading health indicators and who've agreed to help measure and track the progress. So then the next thing I want to talk about is our actual pilot implementation. So how do we get to that? Well, as I said, there are 25 leading health indicators in Alaska. They range from everything from cancer to increasing rural community housing units with water and sewer, things like reducing obesity, increasing access to medical care. So we have a lot of different leading health indicators, but we knew in our implementation phase that we wouldn't be able to do all 25 all at once. So we decided to focus on 3 to 4 in this first year to really think about how we could implement those in a successful way and then expand that to the other, the remaining 25 total. We had a core team. As I said, the core team that works on Healthy Alaskans narrowed down the 25 leading health indicators to 9 to really narrow it in. And the advisory team for Healthy Alaskans then selected 4 of those for implementation. And those were domestic violence, suicide, tobacco use, and socioeconomic status. So we then decided that for each of those leading health indicators for the pilot project, there would be a coordinating partner. And so there was a selection process. We created the roles and responsibilities for them. And then we asked for volunteers. And so this, of course, as many of you know, asking people to do something brand new that doesn't really have a lot of specifics, that has no money attached, and that is incredibly important for our state. And so we were more than pleasantly surprised, I think I can speak for all of us working on this, that people have stepped up for all 4 of our pilot project lean health indicators. We had individuals who very kindly said, yes, I'm willing to be the coordinating partner for Healthy Alaskans for the state. So as Michael said, we've been working on the creation of this database of all the different organizations working on the different leading health indicators around the state to create that and then be able to provide that to the people, the coordinating partners. Really one of the main things that we want to do is help align a lot of the work that goes on around our state because of geographic issues and just sort of general issues that we all work on many things and don't always know what each other is doing, trying to make sure that we move that all forward in a cohesive manner and move the needle forward on the leading health indicators. And lastly, of course, is what's important sometimes is also measuring that is happening. And so that is another thing that we are working very hard to do, is figure out the ways in which we can measure this implementation and move it onward. So and one of the things that is important for this is that we do have already, as part of the earlier work, we've already developed the leading health indicators, as I mentioned, the strategies and actions around them, and key partners. So it's not like we're starting from new. This, of course, is expanding on the previous strong work that has already occurred. Along with that, we do have, in terms of measurement, we have a Healthy Alaskans 2020 scorecard, which has the leading health indicator, the 2010 baseline, our target, what the current data is, and a symbol for progress to date, sort of a red, yellow, green sort of measurement. And we have this for both overall Alaska and then also for Alaska Native people in specific, so that again from the tribal side we are trying to track our own measures and try and move it forward. There are some unique issues that go on in rural Alaska in terms of access to care and cultural background, and so we use this in the tribal system very strongly to try and make that happen. All of our information, materials, we keep on the healthyalaskans2020.alaska.gov website if anyone is interested in taking a look at how we got to where we are. Of course, our community assessments and all the reports and the things that led us to where we are in our 25 leading health priorities are there, as well as the data that we use. All of it is kept up to date, and the scorecards are issued yearly, but the data on our state, luckily we've had very strong partnerships with our state folks to get the data updated as quickly as it comes out. So there's been a lot of work to date trying to basically figure out how to actually create the implementation. As Michael told you, we have a framework, and then using the previous work that we had done in getting the strategies and actions, and now having our coordinating partners very kindly have come on. And so this is a brand new world for us, and we appreciate anyone who wants to follow up after this. We'd love to talk more about our work or other work in this area.
Thank you, Diana and Michael. And in the last couple of minutes, we have about 2 minutes, let's take a question from the audience. So Namdi, can you open the lines for us?
Yes. At this time, if you would like to ask an audio question, please press *1 on your telephone keypad. That's *1. We'll pause for just a moment to compile the Q&A roster. There are no audio questions at this time.
I see a question from Carrie Allison on the chat.
Michael and Diana, it looks like that question's for you from Carrie Allison, and she asks, what does the organization alignment database look like? And could you explain that a little bit?
Well, it's just a big spreadsheet for now. We've just have collected the data, so we haven't put it into a database just yet. We're still cleaning the data and sorting it and dividing it into the 25 different leading health indicator categories. But it's an interesting question because we've been looking at different places to put the data, to store it. Because as you know, when you have a large database with contact information, it doesn't really stay updated for too long. So we were trying to find some solutions to where there might be capacity to have it updated. Some of those things we looked at was, and that we're still exploring, is 211 database, as well as, and that's through United Way, as well as our Commerce and Development Division. They have a large database that we're considering as well as one that's called AHELP. It's the Alaska Library Health Education Project. So once we figure out what it's going to look like, we will definitely love to share that with you all.
Great, thank you so much. And Namdi, do we have any questions on the line?
As a reminder, if you would like to ask an audio question, please press *1. That's *1.
Well, I think we're just about at time. So I'd like to thank our presenters. Thank you from New York and from Alaska for your great presentation. So as Denise had mentioned at the beginning of this webinar, this is the 4th and final piece of the SHIFT Learning Series. All of these webinars are recorded and they will be available within 2 to 3 weeks. And you will be receiving an email with links to those. If you have any questions in the meantime, please feel free to contact Denise. Her contact information is on the screen. And we thank you so much for participating.